good afternoon, everyone. Let me present my PhD topic, the diagnostics of pancreatic neoplasia. For start, I would like to quickly summarize our first project, that pancreatic cancer is the third leading cause of cancer-related deaths worldwide, with a 5% survival rate less than 10%, and many cases are diagnosed too late for curative treatment. Therefore, there's an unmet need for some quicker and highly accurate diagnostic techniques, such as macroscopic and rapid on-site evaluation supplementary techniques. So our first project, our systematic review and meta-analysis demonstrated that incorporating those techniques during EUS-FNB can significantly increase the diagnostic sensitivity by 5% with MOS and 7% with ROS. So routine implementation in the clinical practice should be applied during endoscopic ultrasound-guided tissue sampling. But unfortunately, more high-quality studies are needed, are essential to understand better these on-site evaluation techniques. And so policymakers, I think, should allocate more funds to this research and to expand access to these techniques. My name is Zoltán Bánfalvi. I'm working in the Institute of Pancreatic Diseases, and our team are working according to a vision that patients with suspected pancreatic neoplasias should be diagnosed as early and as efficiently as possible. Therefore, our mission is to identify the most reliable and accurate diagnostic techniques for it. Currently, we have two ongoing projects. The first one I summarized previously is about the diagnostic accuracy of supplementary on-site evaluation techniques during FNB. The second one is a little bit different. It's a study protocol for acute pancreatitis-related Splanchnic venous thrombosis anticoagulation. For the first project, that pancreatic cancer mortality is a third, with more than 60,000 cases a year in the USA, and the time is the most important factor in its case that a resectable cancer can easily progress to an irresectable state. EUS-guided fine needle biopsy is a standard technique to acquire a sample. It has a high sensitivity and specificity on its own, but sometimes the problem is the success rate of tissue acquisition with it. So they developed two supplementary techniques. The first one is ROSE, rapid on-site evaluation, which is done by an experienced cytopathologist with expensive equipment in the endoscopic room. The other one is MOS, that macroscopic on-site evaluation, which is done by the endosonographist by his or her own eye in the endoscopic room. Our aim is to identify that these methods to acquire the adequate histopathological sample as soon as possible. So the clinical question is that do these techniques improve the success rate of tissue acquisition compared to standalone EUS-FNB? The patients are suspected pancreatic neoplasia patients. The index text is FNB plus ROS, FNB plus MOS, or FNB plus ROS or MOS, ROS plus MOS. The reference test is the definitive histopathological results or the follow-up, and we are looking for the diagnostic accuracy in pancreatic cancer. Our hypothesis is that MOS and ROS can improve the success rate of tissue acquisition, allowing for a better diagnostic accuracy compared to standard EUS-FNB. We conducted a systematic search in 5 different databases last October with the following search key, and after the careful selection process, we identified 32 full text in the main selection part, and with the citation chaser 7 more. So this is the first plot about the sensitivity. The sensitivity is a 2 positive rate, the proportion of the 2 positives in the 2 positive plus false negative samples. The upper group is for ROS, included 7 articles with 1,000 patients, moderate heterogeneity that can come from the different needles they used for the sampling and the different sample number in the studies. We find that the pooled diagnostic sensitivity for this is 95%, and thanks to the multivariate meta-analysis model, we can calculate that it is significantly better than the standard FNB 88% sensitivity. In the case of MOS, we included 17 articles with 1,700 patients with moderate heterogeneity due to the same reasons, and the pooled sensitivity was 93%, which is also statistically significantly better than the FNB without on-site evaluations, which is highly important clinically. We were able to compare ROS to MOS And our calculations show that there is no significant difference in case of sensitivity in these cases, which is also highly important clinically. The other figure is specificity, the true negative rate. In the Rose group, it's 6 articles. The pooled specificity was 94%, and in the Mohs group it was 95%, and they wasn't differ significantly for the EUS-FNB in case in specificity. Compare them to each other. In this case, it was also no difference statistically significantly. So, as all studies, it has its strengths and limitations. The strengths are it has relatively large patient number in each group of methods, and the project includes and evaluates both Rose and Mohs. Limitation is that it's not only RCTs, different study types, retrospective and prospective core studies was included, and unfortunately articles usually don't report all of the examined outcomes. For the conclusions, we can say that these on-site evaluation techniques can increase the sensitivity of the EUS-FNB without on-site evaluation, and in the second part, we may not need expensive equipment for Rose to reach higher diagnostic accuracy. The practice implication is that recommendation may expand with details on on-site evaluation techniques, and the implication for research is that we should design specific RCTs for Rose versus Mohs, and maybe we should establish a national EUS registry to better understand these techniques. This is the progress of our first project. Currently, we are in the end of the risk of bias assessment and starting the grade and the manuscript writing. For the second project, it's investigating the effectiveness of DOAC and LWMH therapies in the treatment of Splanchnic venous thrombosis in acute pancreatitis patients after discharge. We are planning to do a study protocol for a multicentered randomized non-inferiority trial for it. So acute pancreatitis has an incidence of 34 cases per 100,000 people, with a mortality up to 30% in severe cases. There are several local complications to it. One of them is Splanchnic venous thrombosis, which has an incidence of around 20% in all acute pancreatitis cases. It can lead, Splanchnic venous thrombosis can lead to segmental or regular portal hypertension, which can increase the risk to very sharp bleeding. The main diagnostic tools for Splanchnic venous thrombosis are contrast-enhanced CT scans. We can also use color Doppler transabdominal ultrasound for the portal vein, and in selected cases, endoscopic ultrasonography can be used. The current ESTH guideline recommends early anticoagulation treatment, but DOAC therapies for Splanchnic VT is off-label in most countries. Our aim is to determine what is the most effective method of the anticoagulation therapy in these cases. The clinical question is that the use of direct oral anticoagulants are as effective as LWMH in the treating pancreatitis-related Splanchnic VT after hospital discharge. Patients are AP patients with Splanchnic VT at discharge. The intervention is the DOACs compared to LWMH, and our primary outcome will be the recanalization rate of the vessels at a third-month CT scan. Our hypothesis is that these DOAC treatments are non-inferior to LWMH in the treatment of pancreatitis-related Splanchnic VT, and the clinical implication can be that if the PEROS alternative treatment will increase the patient compliance, allowing them for a quicker recovery. For summary, in the end, our first project about different diagnostic techniques in EUS-FNB, we planned to submit it this September. For the second project, the study protocol, we plan to submit it next June. I would like to end my presentation with a quote for Neil deGrasse Tyson, that the good thing about science is that it's true whether or not you believe in it. And thank you for your attention.
Thank you very much. A nice presentation. Any questions from the audience?
Congratulations for your presentation. I would like to ask, what was the main reason behind the development of the on-site evaluation technique?
As I said, that EUS-FNB is good on its own, but in case of pancreatic cancer, it's never good enough. So we must try to find some way to increase its diagnostic accuracy and adequacy values. So they developed first the rapid on-site technique with the cytopathologist, after that the Mohs and the sonographist to examine the sample on his own. maybe this.
Thank you.
Thank you very much. I was wondering, what is your routine in your own hospital? And will you make any changes based on the results that you got?
Routinely, in most of the cases, we use the rows. For now, there is a cytopathologist come over to the endosonographic room and sit there and examine the samples every time we do an EUS sampling. But according to these results, maybe only Mohs is enough. So we can see that there is no difference, significant difference, the sensitivity, so maybe it can be done easier.
How much is Mohs inter-observer variant, and what is the learning curve for that?
What is the, sorry?
The learning curve.
The learning curve, I think it's much easier. The learning curve is much faster than for rows, and you don't need an experienced cytopathologist. So during your regular EUS training to the sampling, you can learn also Mohs too.
What is the inter-observer variance? So, you know, this endosonographist is better than the other to do.
Yes, of course, if you have more experience, it leads to a more accurate results, but I think the inter-observer difference can be decreased if they use the Mohs routinely in the practice, because everyone has a ruler to measure the centimeters. We can see the color, so it's not just it's not that subjective. It's really objective to measure that the Mohs sample is good or not. I think.
I see. Is there what was the needle size?
It is quite different. They only use FNB needles in these studies. Most of them is 20 or 22 gauge needles. With the 22 gauge needles had a slightly better performance in these plots. I have the diagnostic accuracy plot on the right side. It just pooled diagnostic accuracy values on the right side for Mohs. And it means that for 22 gauge needles it's 94%, for 20 and other type of needles it's just 91, and there is a statistically significant subgroup difference in that. So 22 gauge needle is better.
Is there also a difference between the different producers? You know, or was it just...
Unfortunately, that was the plan, to assess that, but we didn't have enough data to properly meta-analyze those, unfortunately. We collected the data, but there are so many different producers and sizes that there are not that much article in this rows and Mohs category to use. Usually they use the 22 gauge needles at them. That's all.
And that this sample is too bloody. It isn't a problem in the evaluation?
Yeah, it's a problem, of course. Then we should do the sampling till we have the clear sample in the tube.
See. Thank you.